Good morning, good afternoon, good evening from whichever part of the world you are all watching. I am Dr. Shivakumar from Madras Medical Mission heading the Adult Structural Program. And with me is Dr. Pramod Sagar, who is a consultant in pediatric cardiology. We are happy to share with you transcatheter structural intervention today. My colleague Dr. Tejasvi will be presenting today the brief clinical details of the patient before we discuss the strategy. Please go ahead, Dr. Tejasvi.
Yes. Good morning, everyone. Today we have a 26-year-old male patient who is an engineer by profession. He was apparently asymptomatic when he was recently diagnosed to have systemic hypertension. He was initiated on medical therapy with amlodipine. Physical examination showed pulses with a blood pressure in the upper limbs of around 174 by 100 millimeters of mercury and blood pressure in the lower limbs of around 100 over 78 millimeters of mercury. CVS examination showed a constant aortic ejection click with long systolic murmur in the left infrascapular area, and his Sussman sign was positive. This is his chest X-ray, which shows a normal cardiac silhouette with no cardiomegaly and normal pulmonary vascularity. Here you can appreciate minimal rib notching bilaterally from the 4th to the 7th ribs, and sign of 3 is also present. This is his ECG, which shows sinus rhythm with a QRS axis of around 75 degrees and LV hypertrophy. His echocardiography in the 4-chamber and short axis view shows significant LV hypertrophy with good ventricular function. He was also noted to have a bicuspid aortic valve with RCC-LCC fusion with mild AR. This is the suprasternal view, which shows post-subclavian coarctation of aorta, and the pressure trace shows diastolic tailing with a gradient of 128 by 40 millimeters of mercury across the coarctation segment. This is the CT aortogram, which shows again the post-subclavian coarctation located around 3.5 centimeters away from the origin of the left subclavian artery. The isthmus measures around 16 into 15 millimeters. The narrowest segment 6 into 4 millimeters, and there is minimal post-subclavian dilatation, and at that point measures 19 into 20 millimeters. We did a CT reconstruction using a immersive software. Here you can see that there are dilated intercostal arteries, and as we slice posteriorly, the coarctation is seen. Now you can see the coarctation with some paravertebral collaterals, which cause the rib notching on the chest X-ray. Here you can see a segmented model of the aorta, which again shows the coarctation quite clearly. The post-subclavian nature and the distance away from the origin of the left subclavian artery can be noted here. This is a heart window which visualizes the lumen more clearly. So as you can see here, we are going to slice from the left. And here you can see the posterior shelf of the coarctation and the luminal narrowing. Based upon our CT measurements, we tried a virtual stent implantation with a 16 into 38 millimeter stent. And as you can see here, the stent is sitting well and is positioned quite adequately, and this will be the stent. Similar measurement stent will be used. This is an angiographic projection. This software can also be used to determine the angiographic projection, which will delineate well the angiographic angle. And here, as you can see, the LAO 90, that is the lateral projection, will delineate the coarctation quite well. Moving on to the case now.
Oh, thank you, Dr. Tejasvi. That was a wonderful demonstration. Basically, you tried to show to us through this new immersive platform that you are able to analyze the CT angiography very clearly. You demonstrated that the immediate post-subclavian part of the aorta, or the healthier part of the aortic isthmus, is measuring almost close to 16 millimeters. And then there was quite a good distance between the subclavian artery to the discrete coarctation. And the narrowest portion of the coarctation is measuring around 6 into 4 millimeters. These are all probably of great importance, no, Dr. Pramod, in deciding about the stent diameter, the stent length. Now, when Dr. Tejasvi projects an aortic isthmus dimension of around 16 millimeters, what will be your choice for the stent diameter?
I would think a diameter of 16 millimeter itself would be good, because there is no ischemic hypoplasia, and
It's
diameter
more of
should
a
be
sort of a
fine.
discrete
It's a
coarctation.
discrete
I think
coarctation.
he's a typical adult type of coarctation who has been by and large asymptomatic because of the extensive collateralization that was leading to an adequate perfusion of the lower part of his body. But he was having significant systemic hypertension. And you said that you documented a upper limb blood pressure of close to 170 over 100
Yes.
millimeters of mercury, which is quite high. Yeah, so we are now dealing with a typical adult type of coarctation with extensive collateralization, a relatively discrete stenosis. Now the choices of stent will be either it has to be a covered stent, which actually increases the safety of the procedure in case of like large aortic tears or aortic dissections. In the CCISC data, it was identified that if the stent diameter is more than 3.5 times the diameter of the narrowest segment, there is a higher chance of aortic wall injury, and in those patients it is very safe to use a covered stent. So now Dr. Tejasvi showed that the aortic lumen is close to 6 millimeters. 3 times of 6 will be about 18 millimeter, and we are planning to do a 16 millimeter stent. So maybe there may be a chance that we may be able to like come out with just a bare metal stent also without being a covered stent. What do you think will be the advantage of putting in a bare metal stent over a covered stent in terms of sheath size and all?
The main advantage that I feel in this case is the sheath size. Actually, if you are planning a 16 millimeter diameter, if you want to use a cover stent, at least sheath French of 12 is required, whereas with the bare metal we can go with 11 or 10, even
10.
a 10 millimeter if
Yeah,
the
maybe we can
stent is having a
cut
lower.
down the vascular access by 1 to 2 French if it is yeah, bare metal stent.
Yes, sir.
And so let us do one thing. Let's get a femoral vascular access. So this is the mid-inguinal point. We are palpating the upper part of pubic symphysis and the anterior celiac spine. An inch below, the femoral pulses are quite feeble. So this is a standard 18 gauge puncture needle. So it's a very low pulsatile flow that I got from this 18 gauge needle. This is a short 3/8 wire that is inserted. We make a small nick and then introduce initially a 6 French standard introducer, and then probably we'll give about 5,000 units of unfractionated heparin. We also I think we have given a dose of pre-procedural antibiotic 1500 milligram of cefuroxime, which has been the standard of care in our institution. So now 5,000 units of heparin is done. So our normal protocol for checking the activated clotting time will be at the end of about 30 minutes of this procedure, we will do an ACT. In case if you are able to complete the procedure before 30 minutes, then probably no ACT will be checked. So shall we have a diagnostic catheter so that we can try to cross the...
I have two questions, sir.
Yes, yes.
Like one question is, like we can see that you have taken only one arterial access, that is the femoral arterial access.
Yeah.
So what is your opinion about taking a additional radial access for check angiograms? Do you
Yes,
think it is mandatory, or when do you recommend it?
It's a wonderful idea actually to have another arterial access from the upper half of the body, and having a control picture by putting in a pigtail across the arch of the aorta. We will be able to position the stent far more precisely. The only downside is that we will be needing another vascular access. One practical difficulty will be when we are taking a radial artery access, and when we try to go onto a lateral view, the right radial access catheter will create some problems for going into a good lateral view. So this is the, let's wait for the femoral artery pressures to be shown. So, this is the femoral arterial pressure. It's quite low pulse pressure. It's recording about 80 by 65. Can you show that in 100 scale so that we see it even better?
And one more question, sir.
Yes.
Now that we know that we have not taken a venous access. That is, we are not planning to pace.
Yes.
So, what is your indications about pacing, and when do you prefer to use it?
Yeah. The rapid pacing basically ensures that the stent does not move across the coarctation segment. So a stent slippage or stent malposition is avoided. It is by and large practiced when the coarctation is relatively mild to moderate. But if it is a very tight coarctation, usually the chances of movement of the stent is relatively less. But your point is quite valid. If the coarctation is relatively mild to moderate, with a reasonably large lumen of the coarctation, it is better to take a rapid ventricular pacing through a venous catheter. Here we are not taking a venous access because from the picture shown by Dr. Tejasvi, it seems like the coarctation is pretty tight. So now we have blood pressure clearly shown at around 76 millimeters of mercury systolic, about 64 millimeters of mercury diastolic with a mean of around 70. So quite a low pulse pressure. It's hardly about 10 millimeters of mercury, and that explains why the femoral artery pulse volume was quite low. So now the guide wire has crossed the coarctation segment. So let's go up.
Yes.
Now let us try to move the. Okay, go inside. So we are entering into the innominate artery. Now we are going into the ascending aorta. Let's check. Yeah, parallel ascending aorta and descending aorta simultaneous pressure and see the clinical gradient. Dr. Tejasvi mentioned the gradient of close to 120 millimeters of mercury on echocardiography. The peak systolic gradient was 120 millimeters of mercury. Let us see the pressure tracing here, both in 100 scales. Right now, the patient is on dexmedetomidine infusion, which probably gives some amount of control of the blood pressure. So here you can appreciate the ascending aortic pressure is close to about 125 to 130, whereas the femoral artery pressure is close to 75 millimeters of mercury. There is a 50 millimeter systolic gradient, and if we look at the mean gradients, it's around 25 millimeters of mercury. So fairly significant coarctation. It was rather easy to cross. Now we will exchange this into a marker pigtail. Yeah.
Yes, sir. In this case, we saw that the crossing was very easy. It was a straight crossing. So when there is significant post-stenotic dilatation, it's anticipated that the crossing might be difficult. The wire just turns back every time goes and hits the aneurysmal segment and comes back. So what are your recommendations during that process, and when do you think what are the reasons for difficult crossing?
Yeah, sometimes if it is a markedly dilated post-coarctation aorta, as you mentioned, this in this aneurysmal descending aortic segment, it may be difficult to target the exact lumen to cross from below upwards. In those cases, if we have a prior CT angiography, we can try to identify where exactly is the orifice, the coarctation orifice located, and using that we can target an appropriate projection in order to I mean, we may be able to cross it correctly. Yet another option will be to have a radial artery access that you previously mentioned. Put a diagnostic catheter in the radial artery, point it down towards the coarctation, cross with a straight tipped guide wire, and snare out that straight tipped guide wire below. So starting with the lateral view angiogram, let's do both a lateral view as well as a AP projection. Give about 25 ml at 15 rate.
Do you think a fusion image, CT fusion imaging, will
It'll
be
be
helpful in those
it'll
cases?
be wonderful. It'll be wonderful to have two types of fusion. Number one is either a CT fusion, which is called heart navigator or vessel navigator, which is basically fusing the CT volume data into the fluoroscopic screen. The second one will be acquiring a rotational angiography and using the rotational angiography 3D data set to identify the best projection. So here we are empirically going with a lateral projection, and now I'm going
And
to
also, I
acquire
think we
the
had
pitch.
used the VMRSI software for which showed the lateral projection would be good.
Yes. So let's make a measurement of this, and once again let's do one AP projection as well, so that we get a orthogonal two views. Little down. Yeah. So it's quite a big leash of collaterals. And so let us make a measurement. Let's do one more angiogram just by pulling the catheter a little deeper. Can you give another 25 ml at 15 rate? So we give 25 ml of contrast at 15 ml per second and at 1000 psi. So let's measure the first angiography and the third angiography. So while we are measuring, in the meantime, let me get this guide wire. Mr. Prabhu, I will get this guide wire into the innominate artery so that we can keep working on the. Okay. Get me the diagnostic catheter. Once I get into the innominate artery, then I will give you time for the measurements.
So now we are planning to place the uh, guide wire in the innominate artery. So you feel that is it the only option, or can we also place in ascending aorta?
We can
Is
place
there
in the
any
ascending aorta
drawback with?
also, since uh, there is a bicuspid aortic valve which is known to cause some amount of cystic medial necrosis of the ascending aorta. There can be a possibility that a hard guide wire may sometimes be traumatic to the ascending aorta. So it may be a good idea to go in for, let's go inside a little bit more. It's entering the internal mammary artery. So let me get it onto the, okay, it's going into one of the lateral thoracic arteries. Because of the anastomosis around the scapula are quite dominant, we have a ampler super stiff guide wire. So this is a 6 centimeter long floppy tip Boston Scientific ampler super stiff guide wire. So we will be positioning it in the brachial artery. We try to avoid the ascending aorta in patients who are having bicuspid aortic valve. To avoid. Okay, now we'll come to the center of the heart. Yeah. Now go ahead with the measurements, please. Let me watch your measurements.
Okay. So you had explained us when the difference between the cover stent and the base stent, but when do you think
12
we
inch.
should absolutely use only a cover stent and not a base stent?
Yeah, if the stent diameter is going to be more than 3 times, we have to use the distance calibration there. We have to use the distance calibration. if the coarctation dimension is going to be dilated to more than 3 times the original diameter by the stent, then probably a covered stent is safer. But if we are less than 3, sometimes bare stent also is okay.
And people also prefer to use in case of calcification, calcific coronary,
True.
like calcified lesion.
Yeah, if there is a
And
calcification, there's a ductal
sometimes
aneurysm, yeah, quite a lot of
what is your opinion in a bicuspid aortic valve? Like a bicuspid aortic valve is an arteriopathy. It's considered to be an arteriopathy. Is there any
yeah, it may be a
indication?
yeah, cystic medial necrosis could be present in the ascending aorta. Okay, go out,
Can you give
get
some?
out,
Can I get a gauze, please?
open it.
Just keep by the side. I should take this out. We'll show live. It's okay. Be here.
அப்படியா நான் அதை சாரை கூப்பிட்டு எழுத சொல்கிறேன். இங்கே கன்ஸ்ட்ரக்ஷன் இருக்கிற மாதிரி தெரியல. பேப்பரா? ஆ ஓகே ஓகே.
Just freeze it. Okay. Enough. Go to lateral view. First view. Go to forward. So we are getting the pre-coarctation diameters around 14 to 16 millimeters. The length of the segment is somewhere around 3 centimeters. So we need to be at least 3 centimeters, if not between 3 to 4 centimeters. So let's get the sheath inserted. We'll make a small nick in the,
Dry gauze, please.
and you get the blade. This is a 10 French dilator. Can I get a 12-inch dilator also? Yeah. Run the two angiograms once again, please.
Sometimes people do measure descending aorta at the level of diaphragm.
Diaphragm.
So
Yeah. That
is
is
it
more recommended whenever you are doing a simple balloon dilatation in a younger patient, where one of the criteria is to target the uh, abdominal aorta. However, when we are doing a stent angioplasty, it is the adjacent healthy segment. So if it is a patient like this having an extremely discrete coarctation, then can we have one small artery forceps? Yeah, make a dilatation of the,
got dry auspice, please.
yes. Let's press here. So let's cross the coarctation. Okay, so I'm taking out the dilator or holding the sheath.
Yes.
Connecting it to pressure so that we see the ascending aortic pressures.
Now that we have taken a non-braided sheet, what is your opinion about a braided sheet in this case, sir?
Since coarctations are relatively straighter segments where there are not much of kink possible, I think a non-braided sheet should be good enough. This is a standard Cook Mullin sheet. We can appreciate that the pressures are about 160 over 90 with a mean of around 120. Can you put it on 200 scales, please? Let's now take the stent. What we need is a 16 into 4 Z-med balloon. 16 into 4 Z-med balloon with 38 millimeter cobalt chromium stent. So this is the 16 millimeter into 4 centimeter Z-med balloon. What is the burst pressure of a Z-med balloon? Is it like 6 to 7, 8 atmospheres? Okay. So this is now we are having the Z-med balloon. Let's also prepare the balloon. Now I want an indiflator. I want a 3-way. So I also want a 20 ml syringe loaded with contrast. Yep. So the 3-way is connected now to the balloon port. I'm connecting the side arm of the 3-way to the syringe. Just inject. Enough. So I give the contrast into the syringe. Turn it around. I'm giving a negative on the indiflator. Now I am allowing the contrast to move inside. I'm again turning it out so that the air from the balloon comes out. Turning it in so that again the contrast gets sucked in. This is the diluted contrast at 1:4 dilution.
This is an excellent demonstration of de-airing the balloon to prevent any air embolism in case of accidental rupture.
Yeah, it's important. It's more important whenever we are doing a balloon aortic valvotomy, where the air that is entering into the aortic root, it is better to totally avoid air. In coarctation also, it's always good to not to have any air at all. So we are doing it 4-5 times in order to get the air out totally. Okay, now let us get this air. Yeah. Yeah. Okay. Little bit more. That's it. That's it. Thank you. So the balloon is ready now. Let's take the stent. I need a short introducing sleeve also. So now we are mounting a cobalt chromium 34 millimeter, 38 millimeter hybrid cell design stent. It's just manually crimped with the fingers. There are people who use mechanical crimpers for this, like for example the type of crimpers that are used in the Edwards Sapien S3 valve, or some people will use umbilical tape to give a good crimping of the stent to the balloon. Here I am primarily using manual crimping. So it's fairly secure.
What are the different bare metal stents that can be used in the coarctation?
Yeah, traditionally the stents that has been used have been Palmas XL, which is available as 4014, 5014. These are the XL series. These stents can be dilated to a maximum of 25 millimeters. The second type of stent is the intrastent Max series, EV3 Max. The EV3 Max is a completely open cell stent. The Palmas XL is actually a closed cell stent, whereas the EV3 XL is an open cell stent, which doesn't foreshorten. The third type of stent that is not available in the the third type of stent is the Cheetham platinum stent, which is a platinum iridium stent, and that is platinum iridium stent is also a closed cell stent, which too foreshortens. And then there are a group of hybrid stents. Hybrid stents are those stents that have a closed end, but the mid part is open cell. So it allows less of foreshortening compared to a standard closed cell stent. Now we have taken the balloon stent assembly towards the region of coarctation. Let us run the angiogram once again, so that in AP view, let us see the orientation of the coarctation in relation to the bronchus. So it's about compared to the left bronchus, it's a centimeter above. So let us pull back the sheath so that we expose 50% of the stent. It's wonderful, wonderful. I think we are reaching the region of the coarctation. So let me make a check angiogram through the side arm of the sheath. I need a 20 ml syringe here without, yep. So I'm actually layering the contrast. This 10 ml is saline, and now the remaining 10 ml that is going to come in is going to be the contrast. So we can appreciate that we have layered the stent. The lower 10 ml is the contrast and the upper 10 ml is saline. So we are going to make a check at this point. We can appreciate the contrast, blood, and then the saline. At this position, so freeze the picture. So Pramod, I think the stent is about 2/3 above the coarctation and 1/3 below the coarctation. Maybe what you can do is expose the stent. Yeah, keep exposing. Okay. Now we have come to the lower pressure. We are now getting the lower pressure. So at this moment, let me repeat one more similar angiogram. So I have layered the contrast 10 ml below. And the top column is the blood and saline. I think we probably can go a little inside, right?
Yes.
So push the stent inside. That should be good enough. Let me make another one more last angiogram. So this is 10 ml of saline. We are layering with another 10 ml of contrast. This probably should be the last check angiogram. I think we should be in a precise position by now.
Yes. You can see 50-50.
50-50, right? Okay. So now I would request the scrub nurse to inform me the atmosphere continuously as I am concentrating on the picture. Keep it pushed. Keep it pushed. Keep it pushed. Yeah. 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 Now relax the. Yeah. Yeah. Okay. So right now I have deflated the balloon. So we can see that the abdominal aortic pressure is becoming a little bit more pulsatile than before. Okay. Position the table. Yeah. So at this position, I'm going to make a check angiogram again. We probably should have contrast because we will need a pigtail, formal pigtail angiogram. We have adequate contrast in the syringe. Yeah. So while we are checking, Mr. Prabhu, the cath lab technologist, now will load some more angiogram contrast. The upper part is reasonably opposed. Let's get a little bit more flaring of the top end of the stent. So now I'm going to tell the pressures now. Okay. So the upper end, we have flared it out. Let's do a pigtail angiogram now. So Pramod, I am going to withdraw the balloon down. So the balloon is coming out. We can use the same marker pigtail so that we can make some measurements. No, we have actually used a bare metal stent in this patient because the lumen of aorta was around 6 millimeters, and we have targeted a 16 millimeter, which now will be around 2.6 times or 2.7 times the coarctation. So whenever we are trying to dilate beyond 3 to 3.5 times the coarctation diameter, it's mandatory to take a covered stent. As you nicely pointed out in the earlier part of the discussion, when we take a covered stent, it needs around 3 French larger sheath. So probably we could have achieved the same result with a 14 French sheath. However, here by using a bare metal stent, we are able to reduce the sheath size. We need to check for aortic wall injury. By the way, Dr. Pramod, did you observe the COAST 2 trials results, which stated that despite using covered stent,
Yes, the incidence of
aneurysms around the
yes,
coarctation stent segment is still
was still
relatively high in patients where a covered stent was used. Primarily, it was about the covered CP stent
yes.
done in the USA. And right. One second. Okay. Just a second. Let us have a pressure transducer. You see the pressures between the upper and lower part now. So now the pressures between, can you open up both are matching, is it? Okay, slightly increase the speed because the red is fusing with the yellow that we are not able to see it at all. Yeah, it's almost sort of similar, matching pressures. So
Absolutely similar.
Absolutely similar, yeah, it's surprising. Okay, anyway, I anticipated that we'll relieve the gradient, but not like this where the two waves are almost fusing on the top of each other that we are not able to differentiate the two colors. Fine, so now we are going for an angiography. Let's give about the same 25 ml at 15 rate. We'll do this in we'll do this in both AP projection and lateral projection. Can you give a little cranial, please? No, not sorry, caudal. Thank you. Little more caudal. Enough. Yeah. So are we ready? Let's review this picture to find out whether there is any possibility of aortic wall injury. So let's freeze it when the whole of the aorta is filled. Yeah, one frame before. Yeah, it looks rather clean.
Yes.
There is some amount of recoil. The stented portion is marginally smaller than the post-subclavian part. However, with the absence of any gradient, probably I am not inclined to post-dilate further. Let's do a lateral view angiogram also. Little up. Okay. So let us get another picture. There are a couple of tiny collaterals that are seen. However, there is no aortic no wall injury. So it looks fine now. And already we have demonstrated that the gradients are totally eliminated. Let's recheck it once again post angiography. Yeah. So yeah, the pressure gradients are completely equal. There is no gradient at all. So let's put in a guide wire. Let's come to AP projection. Now about the vascular access site closure, there are two ways. One will be to use a ProGlide and close it. However, when we started the procedure, we did not take a ProGlide, and hence now we probably have to settle down to a manual compression. So we will be giving a little bit of bupivacaine injection topically to the femoral access site, so that the local pain is significantly relieved, and then we will go for a removal with a manual mechanical compression. Any question?
What is the protocol of follow-up, sir?
Yeah, see, in this coarctation stent angioplasty, since it is a large vessel, it has not been my routine practice to give any antiplatelet agents at all. We look at the blood pressures at the time of discharge from the hospital, which may be by tomorrow evening. If the pressures are totally normal, then he won't get any antihypertensives at all. Right now, as I speak to you, the blood pressure is about 155 by 95 with a mean of 120. This could be due to stretch of the aorta with a lot of release of noradrenaline. The heart rate is well controlled. The heart rate is quite slow. It's only around 65. In case if there is a increased blood pressure at the end of the procedure, we give some beta blockers. The second, by tomorrow, if there is a higher blood pressure, we probably will give a beta blocker with angiotensin converting enzyme inhibitor. No aspirin. First review will be at the end of 1 month, and we will also do a CT angiogram of this patient at the end of 1 year to look for whether there are any small peri-stent aneurysms.
So can we take one question about the reasons for choosing a certain type of balloon during this procedure?
Okay. Why did we choose a ZMED balloon? Yeah, there are quite a few balloons. Like for example, if it is a 16 millimeter balloon, there is a balloon available from the Boston Scientific called as the XXL esophageal balloon. There is also a balloon that is available from the BARD by Atlas. There are ZMED is made by the NewMed Corporation. It has got a rapid inflation and rapid deflation characteristics, which is very, very friendly. So you can deflate it very fast. So our preference for most of the stent angioplasties will be to use a ZMED balloon. But if there is a significant recoil, we probably will think about post-dilating it with an relatively less compliant or rather non-compliant BARD Atlas Gold balloon.
Yes, sir. Thank you.
What is your opinion about bib balloon, sir? Like some people do prefer it.
It's another very, very useful balloon. The advantage of a bib balloon is that we can initially inflate the smaller balloon, that is the inner balloon, and then if our position is not very precise, we can push the balloon stent assembly up or down, because the balloon has been inflated only to 50% diameter. So a 16 millimeter bib balloon will have an 8 millimeter inner balloon. So the initial dilatation will be only to 8 millimeter, and then we will be able to adjust by pushing and pulling the stent, and then making the final final dilatation. A bib balloon will have a marginally higher profile when compared to a regular ZMED balloon. In fact, the bib balloon's outer balloon is a ZMED balloon. The inner balloon is a Taishac balloon. The bib balloon will have a marginally higher profile, whereas the ZMED will have a lower profile. Definitely, bib is also another good balloon in the armamentarium of a stent angioplasty. Any other questions are there, Tejsi?
No, so the other questions were for the first case, which for lack of time we'll be choosing to answer later.
Okay. So it was a pleasure to join the team and demonstrate this stent angioplasty of forced subclavian coarctation of aorta. I'd like to thank Dr. Uday Charan, who is our intensivist, who was managing the patient with a small dose of dexmedetomidine running continuously to make him feel comfortable. Even though there was a slight movement of the patient around the time of the stent angioplasty, stent expansion, the aorta is actually a very painful structure, and it's richly innervated with nerve endings, and a high amount of noradrenaline will be released when we are stretching the aorta, and so brief periods of hypertension may happen. So it has been our standard practice to give agents that control the sympathetic output. The patient, like number one will be beta blocker, and number two will be drugs such as fentanyl or dexmedetomidine. And this patient has been kept optimally sedated so that he's not having any major distress. Now I think you have given a small dose of bupivacaine in the perisheath area. So the way in which we do a manual compression will be, we press the groin a little below the sheath, and now I'm in taking out the sheath. So when I take out the sheath, if there is a perisheath thrombus, microthrombus, it will be washed out by the gush of the blood that comes out from the proximal portion of the iliac artery. So I allow a gush of the blood before I manually compress. So right now we have compressed it. We are giving a manual compression on the top of the femoral artery. The gush of the blood will wash out all the small microthrombus that are accumulated around the perisheath area. If the sheath goes more than 12, then probably we may think about using a ProGlide or another vascular access closure device. One of the reasons why we don't try to take it in a smaller access is because